So first of all, thank you so much, Dr. Janiczek, for taking the time out of your busy schedule to offer this opportunity for our Wayne State University students. My name is Janickez. I'm a PR rep for Club Med Virtual, and I will be leading today's session, reading any comments posted in the chat and facilitating the conversation as we go along. Before we start, I just want to remind everyone to maintain proper etiquette and please keep themselves on mute unless specified otherwise. If you have any questions, please post them in the chat and they will be addressed as we proceed through the session. A Google survey will be administered for Wayne State University students at the very end of the session to verify your attendance and will close 30 minutes after the session terminates. Please stay on the call at least 5 minutes after the session is over to ensure the survey is working for you. This session will also be posted on YouTube in case you're unable to attend or want to revisit certain topics discussed today, but cannot receive attendance hours if you're not present during the call and complete the survey. Other than that, thank you so much, and you can take over.
Awesome. Thank you, guys. Thank you all for coming. Let me just share my screen real quick. Annika, it says that I can't share my screen.
Oh, okay. Hold up.
You should be good.
Okay, thank you. All right. All right, good evening, everyone. Thanks for coming again. My name is David Janiczek, and I am a fourth-year anesthesia resident and also chief resident at the University of Illinois, Chicago, Department of Anesthesia. I'm also an advisor for the pre-med scene, which if you guys haven't checked that out, it's a great pre-med society that was just started a few months ago. They have guest speakers, and lots of great content out on their blog, Instagram, all that sort of stuff. So if you haven't checked them out already, I highly encourage you to do so. And then I'm also founder of a Get Admitted MD, which I'll get to a little bit later in the presentation. So as an anesthesia resident, I'm going to talk to you guys about the fascinating world of anesthesia tonight. So here's a quick outline. I'll just briefly go through it. I'm going to introduce myself a little bit more of the field of anesthesia, go through, what do we consider anesthesia? What's the history? What's a typical day in the life? How do you become an anesthesiologist? And then we will have a case study as well. So a little bit about myself. I'm originally from Iowa. Born and raised. I went to the University of Iowa for my undergraduate and medical school education. So I studied integrated physiology and business administration as a undergrad, and then I graduated from the Carver College of Medicine at the University of Iowa in 2017. I'm currently a fourth-year resident, like I mentioned, at the University of Illinois, Chicago, Department of Anesthesia, where I will graduate in June. And then I'll be going down to New Orleans, where I'll be doing a cardiothoracic anesthesia fellowship next summer at Ochsner Health. So my path to anesthesia started way back in high school. So kind of the first introduction to this was my first anatomy and physiology course, where I just fell in love with the topics covered, especially, physiology, learning how the body works, all those sorts of things just blew my mind at the time. And then during my senior year of high school, I was able to do it was a course that was offered through the community college where I lived, and it allowed me to shadow an anesthesiologist at a local hospital. And that really just kind of opened my eyes to the world of anesthesia, and just the fact that they used all this physiology every single day, giving medications, taking care of patients. It was just extremely fascinating to me. So like I said, in college I studied physiology because that was the thing that was most interesting to me, and I felt like it was a good major to have, with my dreams of going to medical school. I also worked as an anesthesia technician as an undergrad. So, I would turn over operating rooms in between cases, set up equipment, those sorts of things. And what it really allowed me to do was get in front of anesthesia attendings and anesthesia residents at the University of Iowa, and kind of pick their brain, why they went into the field, what they find interesting about anesthesia. And that really allowed me to kind of get an inside look at the field. So in medical school, I did a summer research fellowship in between my first and second years, where I studied ACE inhibitor use and low blood pressure after induction of anesthesia. And I really got, a great experience because my mentor was actually a cardiothoracic anesthesiologist, and he took me under his wing and really taught me a lot about the field. And that really just solidified my, my desires to go into anesthesia. And then I did what's called an anesthesia externship my M4 year in medical school. So basically, I would take extra call during the nights and weekends, and I would serve many of the same roles as I did as an anesthesia technician. I'd set up operating rooms for emergency cases, help out the anesthesia team, all those sorts of things. And once again, it really just got me in the in the field and let me see what the anesthesia residents experience. So it was a fantastic experience to kind of get me ready for residency. So why would you choose anesthesia? There's a whole host of reasons. Here are some of mine. So first of all, my fascination with the interaction between human physiology and pharmacology. I use this every single day, basically every single minute when we're providing, anesthetic care. So you gotta love physiology, learning about how the body works. I think you also have to have a love for the operating room environment. So there's definitely some things that, go on in the operating room that you don't necessarily think about ahead of time, and you really just have to find out that you love it. And so that was one thing that I did is I really just enjoyed being in the operating room. It felt like time was, going slow, but going fast at the same time. And so, I kind of knew that was where I wanted to be for my career. I didn't really want to do surgery because, I just didn't really like the people, to be honest, that go into surgery. It's a kind of a unique crowd, and I just never jived with them versus the anesthesia folks. I just felt like I fit in, and it was easy to talk to, easy to spend time with, those sorts of things. Some other good things, the ability to do procedures. So we as anesthesia providers do a lot of procedures, whether it's epidurals for labor or central line placement. If it's a cardiac case or a big case, we may have to place a central line, so a big IV that goes in the neck here. So we kind of get our hands dirty those ways. We intubate patients all the time. So, kind of those little hands-on procedures that get you through the day. And, it's not just rounding in the ICU, talking about the patients, you actually get to do stuff, which is awesome. Another good thing is that you get to work with different specialties on a daily basis. So one day I may be with ortho surgery, and maybe the next day I may be with cardiac surgery, the next day I'm with transplant surgery. So there's just so much variety that you can do with anesthesia, and you don't have to just focus on one thing. You can do everything if you want. And then one of the big things that has always drawn me to anesthesia and still draws me to anesthesia today is my interventions have an immediate impact on the patient. So if I have low blood pressure in the operating room, I see it on the monitor, I treat it. I know the patient got the medicine because I gave it to them. I don't have to worry about insurance approving it. I don't have to worry about the patient going home and taking a medicine and coming back to see me in 3 months. I give it to them, and I can see the immediate effect on our monitors, which I'll show you in a little bit. And so kind of that instant gratification was something that I really desired in the medical field. And I felt like I never wanted to be the doctor that said, hey, take this pill, come back and see me in 3 months. And I don't know if the patient's going to take the pill. I don't know if it's going to work. And so, that aspect definitely drew me to anesthesia. And it's one of the only fields where you kind of have that immediate impact on the patient, and you can actually know that your interventions are having some effect. The last one is a little bit controversial. So there's very little continuity of care as an anesthesia provider. We don't see the same patient a whole lot. We don't follow them up in clinic. We don't see them. We don't develop a relationship with them. Like a surgeon, a family med doctor, an internal medicine, a pediatrician, all those sorts of fields have some sort of continuity to them. And we don't have that. And I say that could be a negative or a positive because it really depends on you and how you view it. You're never going to be the one that's stopped at the grocery store and say, oh, you were my anesthesiologist. It happens very, very rarely versus, surgeons or pediatricians. They kind of get recognized in the community and they see individuals for a long term versus anesthesia providers. We really impact the patient for a very short amount of time. And then we move on. And so I viewed it as a positive, but I think some people will view that as a negative as well. So what is anesthesia? So we talk about 4 pillars of anesthesia. So the first is analgesia. So that's pain relief. And the second is paralysis or muscle relaxation, which I'll get to in a minute. Third is amnesia or loss of memory. And then fourth is unconsciousness. So you know, when you think of anesthesia, you should think of kind of all four of these things. And you'll see when I talk about how to approach a case, all four of these have to be accounted for, you know, in some sort of way when we're developing the, you know, plan that we're going to do for the patient. On the bottom of the screen, you can see that there's a continuum from awake to asleep. And so in the middle is what I call sedation. So in the awake state, we have various things we can do. Local anesthesia. So if you guys have ever had like a dental procedure or a tooth pulled, you know, that's local anesthesia where they just inject some medicine, you know, right by your tooth, and they, you know, do what they need to, and that provides you pain control. Regional anesthesia is a little beefed up version of that. So basically what we can do is we can numb up, for instance, you know, the entire arm. So if a patient's having surgery on this left arm, we can numb up, you know, that left arm, and the patient doesn't need to have general anesthesia. They don't need to be asleep necessarily. You know, we do a lot of surgeries under what's called regional anesthesia, and that's, as you'll see in a little bit, that's actually a subspecialty of anesthesia that you can go into and focus on for your career. In the middle is sedation or monitored anesthesia care. You guys may have heard about this. So basically, sedation is where we give you some medicines, but not to the point where we need to place a breathing tube. And so, you know, the patient's sleepy, but they're not completely asleep. Some folks will call this twilight sleep. You may have heard about that. So this is for more minor procedures that we don't need to get you all the way asleep for, but we'll give you enough medicines to make you comfortable and get you through the surgery, but you're not necessarily completely asleep. Lastly, on the complete right of the spectrum is asleep. This is called general anesthesia. So that's typically what you think of when you're having surgery or major surgery, that is. So you're completely asleep. We place a breathing tube after you're asleep, and that's how we take care of you throughout the procedure. And then typically we pull the breathing tube out at the end of the surgery, and you go to our recovery area. So there's three phases of anesthesia I want to talk about, and I liken this to planes. So the first step is induction. So you guys have probably all been on planes. Induction is takeoff. It's a very tenuous time where we're getting the patient asleep. That's what the induction phase really is. And so as you can probably imagine, there's a lot of things that can go wrong at this time. And one of the things that we go to training for is to avoid those things. And so this, you know, means that we know how much medicine to give them. You know, everything's weight-based. We need to know all the doses of the medicines and dose them appropriately. And if we don't, then bad things can happen. You know, the airway is an issue at this point. You know, we need to secure the airway if we're doing general anesthesia. Sometimes in certain patients make this very difficult. And so, you know, it's a very, very tenuous time, just like taking off on an airplane. The next phase is called maintenance, and that's, you can kind of think about that as autopilot. So this is after we've induced the patient's fully asleep, and you know, this is kind of the cruising, if you will, or the autopilot of anesthesia. So, you know, there's still many things that can go wrong. We have to be vigilant and, you know, make sure we're watching our monitors and doing everything appropriately still. However, it's not as tenuous of a time as, you know, induction of anesthesia. And then finally, emergence. So emergence is basically landing the plane. Once again, lots of things can go wrong when you land a plane. Lots of things can go wrong when you wake a patient up. So it's kind of the bookends of anesthesia, so the induction and the emergence, that are really difficult times. And so you may see, you know, anesthesiologists a little bit more stressed out at those times. The maintenance phase is typically pretty smooth, but obviously that depends on the patient, what, you know, comorbidities they have. You know, if their heart's, you know, not working as well, maybe that's a little bit more of a rocky time. However, these are kind of, you know, the phases that we think about. So I want to switch gears a little bit, talk about a brief history of anesthesia. I'm not going to go through all this. Basically, my point is anesthesia is a pretty young field, and you know, back in, you know, 1777, that's when nitrous oxide was discovered, so laughing gas. And so it really wasn't that long ago. And then you guys may have seen the pictures and the paintings about the ether dome. And that was kind of the first public use of ether for anesthesia. Obviously, we don't use ether anymore. And so we've moved on to fluorinated hydrocarbons. So there's a couple medicines that we use every day. You know, isoflurane, one of them, sevoflurane is another one. And then the big one, propofol, which I'm sure you guys have all heard about from kind of the Michael Jackson incident. That was actually not invented until 1977. And so you can see that's only, 33 years old. And so it's a pretty young medicine in general. And so in the right hands, propofol is an extremely safe medicine. That's why we trained for 4 years to know how to use it, the appropriate dosing, everything like that. And so it's kind of gotten like a bad reputation over the past, 10 years because of what's happened. But in the right hands, we use it every single day, and it's very safe. All right, so what's a typical day like for anesthesiologists? So you get to the hospital very early. I say usually between 6 and 7, you get to the hospital. You have to set up your operating room, and a picture on the left here kind of shows some of the drugs that you would set up for your operating room. So, sorry, some of these are kind of small, but basically you have some fentanyl, you have some propofol, which is the white medication here, succinylcholine, rocuronium, which I'll talk about in a minute. But that's kind of the basic setup of drugs that we would have ready. And then you visit with your first patient. And so, this is a time, before the operating room's really running, you get to visit with your first patient, confirm all their medical history, make sure there's nothing you need to do for them before you take them back to surgery. And then the start of surgery typically is between 7 and 8 a.m. I would say most operating rooms start closer to the 7 time period. But sometimes, if you're in an academic setting and there's lectures for the residents in the morning, sometimes it's pushed to 8 or 9. But nonetheless, we start early. Sometime in the morning, I say between 9 and 10:30. Typically, we get a morning break, depending on your hospital and your setup and everything like that. Then we get lunch in the middle of the day, and then lastly we get to be done. I put the range, 2 p.m. to 6 p.m. But honestly, it can be quite variable. Like today, I was done at 4 p.m. But a couple days ago, I was done at 8:30. So it kind of just depends on your day. So the path to being an anesthesiologist, so 4 years of undergrad, 4 years of med school, just like every other doctor. And then residency is a 4-year commitment as well. So the first year of anesthesia residency is an internship. So you rotate through medicine, you rotate through surgery, emergency room, all these different subspecialties, and basically you learn how to be a doctor during this time. And so you learn the basics there. And then, so PGY is postgraduate year. So PGY 2 through 4 is basically years 2 through 4 after graduating from medical school. So if you remember from the title slide, I'm a PGY 4, meaning I'm at the end of my clinical anesthesia training or my last year. And so, basically for anesthesia training, years 2 through 4 are where you learn how to be an anesthesiologist. And so you're taking care of patients every single day in the operating room. You still do some rotation, so you rotate through different subspecialties like cardiac anesthesia, neuro anesthesia, OB anesthesia, and everything like that. And then after residency, you can do a 1-year fellowship if you want, and I say plus minus because it's definitely not required by any means. You can go out after a 4-year residency in anesthesia and be a fantastic anesthesiologist, have a great career, be very stable, everything like that. It's definitely not the field that you need to do a fellowship in. However, there are many options for fellowships. Cardiothoracic is an option, which I'm doing next year. OB anesthesia is an option. Chronic pain management is an option, and so on and so forth. And so basically, if you do one of these fellowships, it doesn't mean that you have to do that subspecialty. You can always, get that training, and you can still be a general anesthesiologist all you want. And so that's the kind of nice thing about anesthesia is it's very variable, and it's very you can carve your own path, so to speak. All right. So let's go through a case real quick. And then I see some questions popping up. So we'll do questions after the case. So fast forward a couple of years, you're now a PGY 2 or CA or clinical anesthesia 1 resident. It's your first night of call. You're a Friday night. You got the worst call shift, the Friday night call. It's 1 a.m. and the OR control desk calls you and says there's a laparoscopic appendectomy coming from the emergency room. So first of all, you get up out of bed, dust yourself off, and you start to think about what you're going to do. So you go to the OR and you start setting that up. So what supplies or equipment do you need? So basically you need the drugs, you need something for airway. And so what I'll get to in a minute, but basically you'll have to intubate this patient to do the appendectomy or removal of the appendix. And so you'll need those supplies. You need to make sure you have the anesthesia machine ready to go. Most hospitals keep those ready, but if, for instance, you're in a very rural hospital, you may have to set that up yourself in the operating room. You just want to make sure that you have all your supplies in case of emergency. So as you're setting up the OR, so basically we covered this. What type of anesthesia will you provide? This is going to be a general anesthesia case. So all the way asleep, breathing tube, the whole 9 yards. Do you need any additional IV access? This is a great question. You don't know what the patient's IV access is coming up from the emergency room. Some emergency rooms are great. They'll get you really good IVs that work fantastic. And other times you'll get one that comes up and it doesn't even work. And so you have to place a new IV before you can induce anesthesia and go off to sleep. I will say that IVs are very close to anesthesiologists' hearts. If you have a good working IV, you feel much better and you can, kind of relax. If you don't have a good IV, it stresses you out beyond imagine. And so if you guys talk to other anesthesiologists, you'll see IV access is often, very stressful for us. Do you need an arterial line? So an arterial line is a special IV that goes in the wrist. And it basically measures your blood pressure on a second by second basis. So every time your heart beats, it gives us the blood pressure. It's used for bigger surgeries, not typically for an appendectomy, which is typically considered a lower risk surgery. And so you probably won't need that for this one. So what drugs do you need to draw up? If you think back to earlier in the presentation, we have the 4 phases of 4 pillars of anesthesia. So definitely analgesia. So we'll need to provide some sort of pain control for this patient. Typically fentanyl is something that we use quite often. Other hospitals may use morphine. You can use something called hydromorphone or Dilaudid. Those are very common options. Then how are you going to get the patient asleep? So how are you going to actually make them unconscious? And that's where propofol comes in. So propofol is a great medicine that basically makes the patient unconscious. It doesn't have a whole lot of pain control properties to it. So it's not going to provide the analgesia. That's why we need to do fentanyl or Dilaudid or some other medicine or morphine. Propofol is a great medicine to get the patient off of sleep. And then because we're going to do general anesthesia, we're going to need neuromuscular relaxation or paralysis. We're going to need to use a neuromuscular blocking medicine. So there's 2 options that typically most anesthesiologists are very comfortable with: succinylcholine and rocuronium. And so those are just 2 options, but there's many more that we could draw up. But those are the basic ones that we would probably draw up for the case. So do you need antibiotics? Surgical site infections are, a big thing in medicine these days. Typically, we go off of what the surgeon wants. So if the surgeon has a specific preference on the antibiotics they want, they typically tell us and we can administer them before the procedure. What are the patient's most recent labs? So this is something you're going to look up before you take the patient back to the operating room. There's a couple key labs that we want to know, basically what's their kidney function. So creatinine is a number we look at a lot. You can also look at GFR or glomerular filtration rate. We also look at hemoglobin. So that's a big thing. Is the patient's hemoglobin 6.5 and they're anemic versus is it, a healthy 14? So that makes a big difference, and we need to know that kind of stuff. For a smaller case like this, we don't need to know every single lab value, but those are kind of the big ones that we look at. And then as a resident, you're going to kind of start thinking about what information is your attending going to ask you. So your attending anesthesiologist is going to ask you some questions about the patient. And so we'll kind of go through some of those questions in the next slide. But you kind of start, as you're setting up and doing other things, your mind is still functioning to see, what information do I need to look up from the chart? What information do I need to talk to the patient about? Because I know my attending is going to ask me, and if I don't have the answer, it will be a very bad experience for me. So let's move on. So after setting up, you look up the patient in the electronic medical record or EMR. You find out it's a 19-year-old male. He's 75 kilograms. His BMI is 24. HPI is a history of present illness. So you get that from the emergency room notes. So he had sharp abdominal pain that started near the umbilicus 2 days ago and is now in the right lower quadrant. And then he also has had some nausea and vomiting since the pain started, and his fever is 102 degrees Fahrenheit today. His past medical history, or PMH, childhood asthma, but he no longer takes inhalers. He's never been intubated for his asthma. It's very well controlled. And he no longer even has shortness of breath symptoms. Surgical history is unknown. It was not listed in the note. Otherwise, his family history, a little bit of diabetes in his mother. His father had some hypertension and hyperlipidemia, or high cholesterol, and hypertension is high blood pressure. Social history-wise, he doesn't drink, he smokes marijuana daily, and he does not use any illicit drugs. So now you go see the patient. So you basically confirm the information you read in the chart, and then you ask a few more questions. So a big question we always ask is, have you ever had anesthesia before? And if so, have there been any complications? And so one of the big complications from anesthesia is post-op nausea and vomiting. And so some of the medicines that we give to the patient to keep them asleep, the inhaled anesthetics, they can cause some severe nausea and vomiting after surgery. And so we can ask them if they've ever had that, and there's other medicines we can give them to kind of counteract that, and hopefully it's not an issue afterwards. Is there any family history of anesthetic complications? So the big thing we're looking for here is something called malignant hyperthermia. It's a very rare condition, but basically if we give them either sevoflurane or that inhaled anesthetic, or succinylcholine, the neuromuscular blocking agent, it can cause them to basically have a myriad of symptoms. Basically their temperature goes through the roof. And I'm talking like 110 degrees Fahrenheit. It's super high. They can get like muscle rigidity and die from it. So it's a very serious thing that we need to know about ahead of time. And if they do have a family history of that condition, then we take appropriate measures to avoid those medicines. And then we actually have to do some other things that, basically help prevent that from happening. Obviously, we want to know any allergies to medicines. We don't want to give them something that's going to cause them to have an allergic reaction on the operating room table. That's a very bad thing. And so if we know about the allergy, obviously we just avoid the medicine. And then last PO intake. So PO just means by mouth. So when was the last time they had eaten food? When was the last time they drank anything? This is important information because when we put them to sleep, they can actually, stomach contents can actually come up from the esophagus, go down the trachea into the lungs. This is called aspiration. And if it develops pneumonia, it could be then called aspiration pneumonia. And they can get these really, really, really nasty pneumonias from this. So that's also why, if you've ever had surgery, the old adage was to not eat or drink anything for 8 hours before surgery. That's so that your stomach has time to clear all the contents, food, drink, anything else that may come up when we put you to sleep. And then also we usually end off with a quick review of systems, or ROS. You guys will learn about this in med school. Basically what this means is we go head to toe and make sure there's no other things that we need to be worried about. So I usually start at the brain and then work my way down, and just make sure there's nothing that wasn't listed in the chart and you would actually make a difference for the care of this patient. So the other big thing when we see the patient is the physical exam. So anesthesiologists are super concerned about the airway. That is, besides IV access, airway is something that keeps us up at night. And when you get a bad airway that's difficult, it's very stressful. So this is a classification system. It's called the Mallampati classification system. So basically what we do is we have the patient face us, and they usually sit up, and we look at, we ask them to open their mouth, and basically what we're looking for is going from left to right. We basically look for if we can see the uvula, or this structure right here. Obviously this is the tongue, and we got some teeth up here. And as you can see, there are tonsillar pillars back here at the back of the mouth. And so if we can see all of this, there's a lot of open space here. We can see the entire uvula. That's called a class 1. And contrast that with class 4. You see the tongue, you see the teeth, but all you really see is the hard palate. And so class 4 obviously is worse than class 1. Class 4 is something that may indicate a difficult airway or a difficult placement of a breathing tube. And I say may because it's not 100% accurate. You can still have class 1 airways that are very difficult, and you can have class 4 airways that are very easy. It just kind of heightens our awareness of which airways we need to be more concerned about versus ones that may not be as concerning. And then class 2 and class 3 are just in the middle. So class 2 is a little bit better and is more like class 1. Class 3 is more like class 4, but still a little bit better than class 4. And so you can see a little bit less space here in class 2. You can still see all of the uvula. There's still some space here, but you can't see all the tonsillar pillars. And so we would call that a class 2 airway. Class 3, you see really just a part of the uvula here, and then you really just see the soft palate back here, and then part of the hard palate. You can't really see any of the tonsillar pillars, and once again, less space in general. And so luckily, our patient tonight is a class 1 airway. Typically, these are the patients that are young and healthy, non-obese patients have more class 1 airways than class 4. So another thing we look at, or a few other things actually, so other airway exam characteristics, something called the thyromental distance, or TMD. So the picture on the right here shows what the TMD actually measures. So it's the tip of the thyroid cartilage here to the tip of the mentum, or tip of the chin or the mentum, and we have the patient extend all the way up. And so we measure that distance. Sometimes it's in fingers, so finger breadth. So you may, have the anesthesiologist kind of, put their fingers there. Other people measure it in centimeters. But basically, if it's short, so short TMD is associated with a more difficult airway or placement of a breathing tube, versus a longer TMD is associated with an easier placement. And then we also look at mouth opening. So, if the patient can't even open their mouth, it's going to be very hard for us to, place the breathing tube, versus someone who has free motion of their, mandible. That would be easier to get a breathing tube in. And then other physical exam characteristics, obviously we want to look at their heart. So the cardiac rate and rhythm, any murmurs we appreciate. Respiratory wise, lung sounds are very important because if there's any changes under anesthesia that we notice, and more specifically, say their saturation, their oxygen saturation starts dropping. Obviously, we want to know what their lungs sounded like before we put them to sleep, because maybe they have pulmonary edema or fluid in their lungs. Maybe there's another process going on, and we want to know what their lungs sounded like before we put them under anesthesia, so that we can compare if anything bad happens. And then I've harped on this multiple times, IV access. We want to know what IVs we're working with when the patient arrives. So after we do all that, we come up with an anesthetic plan. So typically this includes pre-medication. So we use something called midazolam or Versed. It's like a liquid Xanax or Valium. So if you've heard of those medicines, those are pill forms, but this is a liquid form that we inject in the IV. Basically, it doesn't put the patient to sleep. It just makes them more comfortable and calm. And then typically we give this before we head to the operating room, because it also has some amnestic properties. And so the patients who get midazolam or Versed, they don't typically remember actually going into the operating room, and that's what we want. It's a very stressful environment for many individuals. We deal with it every single day, so it's very normal to us, but for many people, it's not normal. It's very scary. There's lots of lights, there's lots of equipment, and so it's very nerve-wracking sometimes. So by getting this medicine on board, sometimes we can alleviate some of those concerns. Induction of anesthesia, for the most part, we use IV medicines for that. In children, we do use the inhaled anesthetics or laughing gas sometimes to get the patient asleep, because most of the time children don't come to the operating room with IVs. They need to be asleep before an IV can be placed, because obviously needles and children don't mix very well. So it's one of those things where, if the child is okay with the needle and maybe they've had surgery before, we can coerce them into getting an IV ahead of time. But most of the time in those situations, we'll just put them asleep with we'll just use gas to get them asleep, and then we'll put an IV in afterwards. So IV induction, I talked about fentanyl, propofol. For this patient, we're going to use succinylcholine, just because his MPO status is not the best. And so, like I mentioned, we typically like 8 hours from the last solid food. Unfortunately, he is only sitting at like 5 hours. So we're going to do a special type of induction, which is kind of outside the scope of this talk. But anyway, we'll use succinylcholine and then we'll intubate. So how do we intubate? I've included multiple things here on this screen, lots of toys. We have lots of toys as anesthesiologists. So I'm going to start down here in the middle, in the center, and this is called a laryngoscope, or a direct laryngoscope. This is kind of the old style of intubating someone, because basically what this is it's a battery. It's a large battery with a light source, and the light is right here. And if you can imagine, this will actually come out. It kind of flips open. And then that's what we put in the patient's mouth, which I'll show you in a minute. But basically, there's no camera on this. There's no fiber optic, nothing like that. Basically, you use it to move the tongue out of the way, and then you can see the vocal cords. And so if you look at the top left picture, this is called a video laryngoscope. The brand name here is called GlideScope, but there's other brand names out there. And so basically what this is it's you can see this provider is holding this, moving the tongue out. So the tongue is right here, moving the tongue out of the way. And there's a little camera at the end of this laryngoscope that basically shines down into the patient's larynx and shows us this picture on the screen. And so what you're looking at on the screen is basically the patient's vocal cords. And you can kind of see the epiglottis right here, but mainly the vocal cords. And what we're trying to do is place the breathing tube right through the middle of those vocal cords, because beyond that is the trachea, and that's where our target is for intubation. Down here on the bottom left, these are just a variety of blades. There's two big types, one called Macintosh or Mac blades. These are the curved blades that you see here. Obviously, this one's very small. This is for a child or a neonate, and then obviously you get bigger sizes for adults. This straight blade is called a Miller blade, and so typically we use more Miller blades in kids, but we can use them in adults too. It's just kind of provider preference. Up in the top right corner, this is another type of video laryngoscope, just like this one, but the difference here is that this little screen attached here is not attached to a pole or anything. It's very small, it's very portable. It's great for intubating in the ICU setting. And so essentially it's the same thing. We have a little camera at the end of this this contraption here, and then it projects an image here. In real life, it's probably maybe 2 inches by 2 inches or so. It's a very small screen versus this is much bigger. And so for teaching purposes, often we'll use this because we can allow junior residents or medical students to kind of see what we're looking at. Lastly, in the bottom right here is this is a fiber optic intubation. So this provider is holding a fiber optic scope. And as you can see, it's not super easy to see. However, this screen right here is projecting the image at the end of this fiber optic scope. We use this type of intubation technique for difficult airways because this fiber optic scope is flexible. It's also what I would call drivable. So there's a little you can't see it, but the provider's thumb is basically moving a lever that changes the direction of the tip. And so we can spin we can move the tip and basically guide it to where we want. So we can guide it right through the vocal cords where we want it to go. And it's a really fun, it's really fun to know how to do, but it's also very, good to know how to use those types, because in an emergency, if you can't use any of these other tools, if you know how to use this, you can save a lot of patients' lives. So this is actually the act of intubating. So as you can see, this is a direct laryngoscopy technique. This provider is holding the laryngoscope in her left hand, his or her left hand. And then this is the breathing tube, or the endotracheal tube right here. And so you kind of, use the laryngoscope to pull open, to pull the tongue out of the way. And then the breathing tube slides in behind it. As you can see from this picture, the esophagus is right below the trachea. So it's very easy to go into the esophagus. That's a common thing that happens to new anesthesia residents or medical students who are trying to intubate someone. They put it in the esophagus, and it's colloquially referred to as putting it in the goose. So you'll get a little bit of flack from your, the people around you if you put it in the goose, but it happens to everyone. You just have to do it once or twice, and then you do know how to do it after that. So anyway, the trachea is our goal, and then as you can see, we leave it above the split between the trachea and the bronchi, it's called the carina. So we leave it above the carina so that this breathing tube inflates and deflates both lungs equally. So this is just a zoomed in version of what that anesthesia provider may see. And so once again, we have a different grading system for this view. So we talked about the Mallampati score before. This view is called the Comac-Lehane score. So it goes from 1 to 4 once again. And so grade 1 is the best, grade 4 is the worst. Grade 1 view is basically where you see all of the vocal cords. So they basically come together at the anterior portion. Lots of open space here. The epiglottis is really out of the way. And then you can place the breathing tube very easily through there. Grade 2, you see a little bit of the cords peeking out right here, but this epiglottis is really covering everything up. You can see the arytenoid cartilages right here as well. So a grade 2, you can often just slide the breathing tube in underneath there and intubate the trachea, no problem. Grade 3, obviously, you don't really see much of the anatomy that we want to see. You basically just see epiglottis and oral pharynx. That's not a great view to intubate on. So either you need to change your position, change your blade, change your technique. There's a lot of things that go through our minds as we're doing this. Basically you need to try to get to this view every single time, or at least the bare minimum get to this view. Once you get a little bit more skilled and a little bit more senior, you could, intubate this one very easily. For juniors or people just starting out, often, we strive for this view. If we don't get it, someone senior takes over and makes sure that they can get a good view. And then, as long as the patient's okay, then they can keep trying. Lastly, grade 4, really, you just see the tongue. So this, bumpy structure right here is really the tongue. You see none of the vocal cords at all. This is not really a great view to intubate on. So you need to do something to change your view in that case. So luckily, our patient tonight is a young, healthy gentleman who has a grade 1 view. So it's very easy to intubate the trachea. All right, so the patient's intubated. Now what do we do? So is it time for stock, Sudoku, crosswords? Not yet. So like I kind of mentioned before in our plan, antibiotics are important. We need to know which ones to give and make sure we get those started. We need to make sure we turned on the inhaled anesthetic to keep the patient asleep, because the propofol we gave the patient to get them off of sleep is only going to last for a certain amount of time, and we need to keep them asleep. And so in order for them to not fight on the breathing tube that we just placed, anything like that, we need to turn on the inhaled anesthetic and make sure they stay asleep. Positioning goes through our mind too. If it's, for this surgery, we don't need to change the position. However, if the patient needs to go prone, for instance, for a back surgery, after we get the breathing tube in place, we flip them over and put them on their stomach. Those types of things need to be accounted for. Neuromuscular relaxation. If you remember before, I used succinylcholine before. So now, because we got the breathing tube in place, it's a secured airway, then we're going to use rocuronium, which is a little bit longer acting. And so we can use that for the duration of the procedure. And then you kind of think about, IV access, arterial lines, central lines, which in this case, we don't need to do. So now is the time for Sudoku, and it's almost, but not quite. So as a surgeon is starting their procedure, you notice that the blood pressure drops from a nice healthy 126/78 to 79/49. So what happened? These things come up all the time, and as anesthesia providers, you need to know what you need to do to fix it. So it's not just knowing the problem, it's that thinking, how do I fix it? How do I fix it quickly and make sure it's, safe for the patient? So because this is a laparoscopic procedure, so basically they're not making a giant incision, it's more of a minimally invasive incision. They use cameras to do their surgery that they insert through little ports that they make in the abdomen. And so basically what they need to do is they blow a bunch of CO2 into the abdomen and make it expand. And so that gives them space to use their cameras and their instruments effectively. And so what this can do is it drops the venous return to the heart because all the intra-abdominal pressure, basically meaning that the heart isn't as full as it once was. So when it beats, the pressure is not as great. And so therefore you get a huge drop in pressure, blood pressure that is, when you insufflate the abdomen. So treatment-wise, IV fluids, medications, or pressors, we call them often. And then if it's really bad and you can't fix it, you can ask the surgeon to decrease the insufflation pressure, and sometimes that works. So what do anesthesiologists actually do during the surgery? So this is just one screen that we look at. This is another screen that we look at. So on the left, you can see a bunch of numbers, some tracings, all of the above. So basically, we're monitoring the EKG or ECG, the electrocardiogram. This gives us a heart rate in beats per minute. So we can detect many things from the EKG. The patient can have a myocardial infarction or heart attack under anesthesia. We could see that on an EKG potentially, and other various changes. Really fast heart rate, really slow heart rate. Different rhythms we can see with the EKG. All those sorts of things. Next up is SpO2 or saturation of oxygen. So basically, this is a nice waveform. And then it also gives us a number, so 95% is pretty good. Obviously, we would like it to be 100%, but typically, like if it's above 92%, it's fine. We can always go up in the oxygen. And then lastly, the CO2 waveform. This is these rectangular square kind of square boxes here. And so that's basically measuring the end tidal CO2, so the CO2 that's expired by the patient. And we have that because the breathing tube is in place, and we hook it up to the anesthesia machine that measures all of that. And then temperature is another big thing that we monitor during surgery. Obviously, we don't want the patient to be cold, but we also don't want them to have a fever. So we kind of have to make sure it's balanced. And then blood pressure. This is a non-invasive blood pressure. So it's a blood pressure cuff that's on the arm. Like I mentioned before, the arterial line would be more of a tracing. And so we could see the blood pressure in a different way, and we would get a number from that tracing. But this is a blood pressure cuff blood pressure. On the right here, this is kind of the screen we look at for all the ventilator parameters. And so we can change the percent oxygen that we're giving the patient. So this patient's getting 70% oxygen. The other things that we can tell is what inhaled anesthetics do we have on board? What are their levels? This is so MAC. This number 1.6 is a measure of how deep the patient is in terms of anesthesia. So a MAC of 1 is, pretty good. This patient's a little deeper than that, but, I don't know. This wasn't a patient that I was taking care of. This is just a picture that I found. So I don't know the exact situation. And then lastly, these are kind of respiratory patterns that we can see, and the machine is monitoring. We can, check their tidal volume. We can check their minute ventilation, make sure they're all within the normal limits, peak pressures, plateau pressures, all those sorts of things are measured as well. And then lastly, at the bottom here, this is where we kind of set the ventilator settings that we want. So we can set a tidal volume that we want. We can set a frequency that the ventilator is breathing at, and we can set other things as well. So fast forward to the end of the case. And so if you remember from the beginning, we're now going to do emergence. And so in order to do that, we turn off our inhaled anesthetic, and it's not an instant thing. It usually takes a while for the patient, depending on the length of the surgery. The longer the surgery, the longer it takes to wake up. But basically, once we turn off the inhaled anesthetic, our goal is to wash out all of that inhaled anesthetic from the body, because it can be kind of stored in your body if it's a long surgery for multiple hours. And basically, the only way to get rid of it is to breathe it out. And so we give the patient typically 100% oxygen, and we kind of just replace all of the inhaled anesthetic with oxygen. And then other big things we do, we reverse the neuromuscular blockade. And so we don't want the patient to wake up being weak. So one thing we do is to make sure that there's no more neuromuscular blockade on board. So we reverse them. And then the goal is to extubate the patient immediately after the last stitch or whatever bandage is being placed by the surgeons. I will say in an academic setting or a teaching hospital, this happens very, very, very rarely. In the private practice setting, where you're working with the same surgeons every single day, you kind of know how long it takes them to close a specific wound. And so you plan it out much better. In the academic setting, obviously you have residents, you have fellows, you have teaching med students. All those things kind of take up more time, and you don't know exactly how long it's going to take to close the incision. And so, one thing that's hard about working in an academic setting is that, you may spend more time in the operating room waking the patient up, just because you may not have timed it correctly due to these unforeseen, factors. So what happens after the case? So we transfer the patient to the post-anesthesia care unit or PACU. We make sure the vitals are stable and the pain control is adequate. We also monitor for post-op nausea and vomiting. And like I said, if there is any of those symptoms, we can, give them medicines to help correct that. For this case, appendectomy, the patient could be discharged that same day. But it really depends on what the surgery team's protocols are. Some hospitals don't like to discharge patients at 3 a.m. when this case probably finished. If it was a daytime case, they could probably go home a little bit easier. So we kind of leave that to the surgical team unless there's any anesthetic complications that we have, and then in which case we try to persuade them to keep the patient in the hospital overnight and then reevaluate in the morning. So if there's no more cases tonight, then we can go back to go back to sleep and wait for the next phone call. So I just want to summarize before we get into questions. So anesthesia is a great, exciting field of medicine. You get tons of variety procedures, and if you love physiology and pharmacology, it's the greatest field for you. One of my attendings once told me this: anesthesia is 97% chill and 3% complete chaos. And so that's why that's really why we train. For 4 years in terms of, we need to know how to deal with the chaos and deal with it quickly and effectively. There's no sitting around, thinking about stuff or, what could it be? We kind of need to know what it is and diagnose it very quickly, and then, make sure we can treat it effectively. There are some downsides to anesthesia. Sometimes the hours can be long, exhausting, and stressful. And also I will say that it's unpredictable at times. And so, it's often, you don't, especially as a resident, you don't necessarily know when you're going to go home that day. It could be, like I said, as early as, noon. It could be as late as, 10 p.m. It could be later than that. You really just don't know sometimes. And so residency is a little bit harder for that sort of thing. You can't really plan a whole lot of activities for the evening. If you have, significant others that you want to go have dinner with, it's very hard to, it's very hard to plan. As an attending, once you're done with training, you can predict it slightly better, but also it's very hard because if you have an add-on case that you have to do, that may delay, your leaving the hospital and those sorts of things. Like I mentioned at the beginning, there's not much continuity of care. Once again, it's a downside to some, it's a positive to others. So it just depends on how you look at that. And then your practice can be determined by surgeons and or hospitals that you work in. So if your hospital does a lot of orthopedic surgery, you may get, pulled into orthopedic cases a lot more. Vice versa, if you're working at a cardiac center and, you don't really want to do cardiac cases, you may have to either, work around that or just, make sure that you find a job that you don't necessarily have to do cardiac cases for. So with that, I will take a break, open it up for questions. I see some in the chat already. So we can just kind of get started here. All right, how many surgeries are you typically involved in per day? So that is completely dependent on the day. So if you do shorter cases, so typically those are urology cases, ophthalmology cases, so we do a lot of cataract surgeries where we, provide anesthesia. Those are typically days where you may do 8, 10, 12 cases in a day. If you're doing longer cases, such as, cardiac bypass cases, something like that, at our hospital, we typically do 1 of those a day. Some hospitals may do 2 or 3 a day. It just kind of depends. And so it depends on, how big the surgery is. It depends on, how busy your hospital is, all those sorts of things. But, anywhere between 1 and 10 cases a day, I would say, is at least possible. So the next question, when the patient is under the maintenance stage, do they still have the ability to get nervous, anxious? And if so, how does that affect your job during the procedure? No, so, the patient's not really, or the goal at least is that they're not feeling anything and, they're completely asleep. So you don't know if they're nervous or anxious because, the only real way that you know if they're potentially feeling anything is their vital signs. So their heart rate and their blood pressure are great indicators, that they may need more pain control. So if a patient, is stable, and then all of a sudden they get, tachycardic, or, basically their heart rate goes up or their blood pressure goes up, and you kind of have a differential that you go through, and you kind of check each thing off a list. But one thing is pain control. You can always give them a little bit more fentanyl, a little bit more Dilaudid, anything like that, if you think it is pain. And so that's one thing as an anesthesiologist, is that you need to decide, why is the patient's vital signs changing, and what do I need to do, based on that change. And so, if you think it's pain related, then you can obviously give more medicine and give more pain control. If it's, a variety of other reasons why they may have vital sign changes, you kind of just go down the checklist and make sure you think of everything, and make sure you rule out things that it's not, and then move on to the next thing. Is there an advantage to waking the patient up immediately after the last stitch? So it really depends on your hospital setting. So in the private practice setting, yes, because in the private practice setting, time is money. So every minute that you stay in the operating room, waiting for the patient to wake up from the anesthesia is, another minute that they cannot bill for, for the next patient. And so it's basically, it decreases the number of surgeries you can do in a day, if you think about it like that. So in the private practice setting, it's all about money, it's all about efficiency. And so the more surgeries you can pack into one day, the better. And so surgeons are going to get mad at you as the anesthesia provider if you're not, waking the patient up effectively and not getting them, to the next case, and then, kind of getting through your day. If you're just, sitting there waiting for the patient to wake up, for an extended period of time, obviously it's gonna, the surgeons are going to be a little bit more upset with you. And then, so it's not necessarily, a bad thing for the patient. It's just more, if you want to, make sure that you're, liked by the surgeons, and kind of maintain that relationship as well. In the dental offices, we use a lot of lidocaine, septicaine, carbocaine. How much do these anesthetics differ from the anesthesia? So we use lidocaine all the time. That's a very common drug that we use. I've never used septicaine or carbocaine at all. I don't even think my hospital has those. And so, obviously all the medicines that end in cane are very, I would say they're cousins of each other, if you will. And so in that regard, they're not that much different. However, there's different molecular properties of each. And if you guys are in organic chemistry, you remember molecular properties can change how certain, molecules act and certain compounds act. So, those things, are probably minute in terms of differences. And it's probably a cost thing. Maybe those are cheaper than the medicines that we use, or maybe they're more expensive. I don't know off the top of my head, but they're not so much different than, lidocaine that we use every single day. So have you ever had a patient wake up under anesthesia in the middle of a surgery? So no, there's a term called, the patient's getting light. And so what that means is that the patient is, maybe we need to give them a little bit more medicine. But I've never had anyone, straight up wake up in the middle of surgery. And I hope to never have that experience, just in terms of, it causes a lot of PTSD for the patient, and it can be very detrimental to their future anesthetics, in terms of maybe they don't even want anesthesia ever again because of this one experience. So it's kind of our worst fear, is having a patient wake up in the middle of surgery. And, it's one of those things that we do everything we can to prevent that. What do you think the future of anesthesiology looks like, job outlook wise, especially given increased CRNAs or some of the stereotypes and myths? Okay, so first of all, the CRNAs, I gotta be honest, they've been around for a long time. When I was a pre-med, everyone was talking about CRNAs are gonna take over, they're gonna take all of our jobs. Some people were saying don't go into anesthesia. And that was 2008, 2009, over 10 years ago now. And so, obviously anesthesiologists are still around. We're still, very in demand, I would say. There's actually, an anesthesiologist shortage in the country right now. In terms of going forward, CRNAs are going to be part of the care team model, but I don't believe they're going to take over anesthesiologist jobs for 100% of the anesthesiologist jobs. And so, some ways that you can, protect yourself against the CRNAs. One is you can do a fellowship. So, that's one reason why I'm going into a fellowship, is because, getting that extra training will only help me and help separate myself from, the CRNAs. And the other thing is, a lot of CRNAs that I've met, they don't want to do, the complex cases. They don't want to do the heart cases that are stressful. They don't want to do the liver transplants that are stressful. They don't want to do the, the neuro aneurysm clippings, the intracranial cases, for instance. They don't necessarily want to do those, because it's a lot of stress. It's a lot of, a lot of things. And so, some of them that I've talked to, they just, they want to do the lap appies, the more simple cases and just get paid, which is fine. That's totally fair. And, I think there's a place for both of us, in the anesthesia world. Some of the stereotypes or myths of anesthesiologists, most people think that we're all chill and we're very laid back. That one is, for the most part, true. Most of us, besides the quote about 97% chill, 3% complete chaos, I always, kind of talk about anesthesiologists is, we're very laid back for, that 97% of the time. And then that 3%, we turn into very type A people, and we're very intense. And so we kind of have to have both gears, if you will. And, that's definitely one big stereotype. The one myth I would say is that, at least not that I've seen, is that we do not do stocks and crossword puzzles and Sudoku in the operating room. It's not, it's not that easy of a job that we can just do all those things, do those things while we're taking care of the patient. We have to take, we have to constantly look at the vital signs, make sure everything's stable, and there's nothing we need to be worried about. So yeah. Have any of your patients ever had an extreme reaction to anesthesia, particularly in the OR? Yeah, I've had a couple, allergic reactions or presumed allergic reactions in the OR. Typically the patient's asleep at that point, and so antibiotics are a common source of allergies. And so if the patient doesn't know they're allergic to something and we give them, an antibiotic that they, are in fact allergic to, that can cause, a allergic reaction. However, usually, we can't ask them, hey, what are you feeling? Are you feeling sick? Are you, does it itch? Anything like that, obviously they're asleep. And so what we have to do is we look at the vital signs. And so low blood pressure is a pretty common vital sign for an allergic reaction. And so, if they have just a precipitous drop in blood pressure and we can't get it back up, sometimes that is then, we think it's maybe an allergic reaction. And then, we obviously have to treat that appropriately. So in the case you must admit an unconscious patient into surgery, how do you decide what anesthetic to give them and what quantities? So if we don't know, when the last time they ate was, or when the last time they had, fluids, then we treat them like they're we call it treating them like a full stomach. So we treat them like they have a stomach full of steak and potatoes. And we kind of change our anesthetic based on that. And so, when we, induce them for anesthesia, obviously we have to, secure the airway, and that's our biggest concern. And so one thing that we can do is it's called a rapid sequence induction. And so basically it's just a quicker way to get the patient asleep, get the breathing tube in. And then once the breathing tube's in, we feel pretty confident that no fluid or food is going to go from the esophagus into the trachea and into the lungs, because that breathing tube basically blocks off the trachea. And so nothing can really pass through that. And so that's called securing the airway. The other things that we can do include, we can actually give them, when they're going out to sleep, we give them cricoid pressure. So basically we try to collapse the esophagus and, try to prevent food from coming up that way. So there are things we can do, if we don't know exactly when they ate or drank last, we can kind of modify our plans accordingly. So I've heard some people having their nerve frozen before surgery. Have you ever done this, and what impact does this have on recovery? I guess I don't know exactly what that is being referred to. Now we do nerve blocks, you know, and that's not freezing a nerve. That's where we use medicines like lidocaine, or there's a couple other, there's one called bupivacaine. And so it's a local anesthetic that we place around the nerve. And basically we use an ultrasound image, and we find the nerve that we want, and then we place local anesthetic around that nerve. And basically, it's a temporary way to block the nerve from transmitting any sort of pain, or knowing that there's pain involved. So, for instance, if you're having shoulder surgery, we could do a nerve block on the brachial plexus, which is up here in your neck, and basically it will cover your entire shoulder, and you know, basically provide post-op pain control for that. You typically, you know, you can do some surgeries under nerve block alone, but sometimes you need to do nerve block plus general anesthesia, so you still need to go off of sleep for some surgeries. In terms of impact on the nerve, it's a reversible thing, and so once basically what happens is you leave that medicine near the nerve, and so for instance, if it's here in the neck, the nerve sheath is porous. And so essentially it'll just dissolve out of the, it'll just dissolve away from the nerve. And so depends on what medicine you use, but it can last anywhere from 8 to 48 hours, where that nerve is basically not firing any times in that period. And so you won't feel the pain there. And so once that time period, you know, ends, you may you're gonna get sensation back. And so typically that's, you know, a day or two after surgery. And so it does come back. And then in terms of recovery, you know, it's a great way to recover from anesthesia, because it provides really good pain control if the block is working really well. And so, you know, you can, you know, it's a great, you know, way to do anesthesia and kind of supplement it. If you do have to go off to sleep, you can still do a nerve block and help the patient quite dramatically, actually. So is a nerve block the same thing as an epidural? How are the procedures different? So an epidural is a very specific type. We call it neuraxial anesthesia. So neuraxial just basically means it's near the spinal cord. And so we use epidurals for labor and C-sections more often. In the last couple of years, there's been a larger push to use epidurals for big abdominal cases. And so, you know, if a patient's getting part of their colon resected, for instance, you know, we could do an epidural for that. And basically what that is we do you could think of it as a nerve block, but it's really more of a neuraxial anesthesia. So basically you know, we're working in the back to place the epidural. And so it basically numbs up an area of your body. And so for labor, obviously you want the patient's contractions to go away, essentially. And so, or the pain from their contractions to go away. And so what happens is we place it usually in the lumbar area for a labor epidural, and for the lower back. And so what that does is it basically covers the area where the contraction pain originates. And so that's what happens in the pregnant mother wants an epidural is, you know, we place it, and then, you know, we keep giving her that medicine that basically shuts off the nerves, supplying, you know, the area where she's having contraction pain. And then once she gives birth, we turn off the epidural, and basically that sensation comes back within a couple hours. And so it's a very reversible thing, just like a nerve block would be for like a shoulder surgery, for instance. So it's similar in one way, but it is different, you know, nerve block versus the epidural in many ways. So.
All right, guys. So if you have any questions, please feel free to ask. But I know some people private messaged me saying that they had to go. But if you have any questions, please post them in the chat. But other than that, thank you so much for this incredible and insightful session. I really enjoyed that it was extremely informative and interactive. If you would like to post your social media handles in the chat, please feel free to do so. To our Wayne State University students, make sure you please complete the survey that Mohammed has posted in the Zoom chat, summarizing the session to obtain your shadow offers. And other than that, if you have any questions, you can post them, but have a great night.